Look at his focus on.
Yeah, so you gotta compete with that now.
That's pretty good.
Your kids,
Right.
Let your kids give those to you, right?
These were, yes, Christmas gifts. Do I need to stand a certain place or can I walk around?
You can walk around if you'd like. I'm
Okay.
gonna get this back up and running.
So I asked Beth, well, what do they want to hear about? She said, well, probably something about COVID and probably
How it's
something about
affected the clinic,
and how it's
yeah.
affected the clinic and the world. First, let's talk about masks. What do you think about masks? Isn't it kind of confusing? Right? When to wear, when not to wear. The biggest challenge is you don't get a second chance to have worn it once you find out that you've had lunch or met with or a gathering with friends or family who test positive days later. And that's something that I've learned firsthand. My wife has laughed because we got 2 girls in college at UF. And I test them before they're allowed to come in the house. Now, is that 100%? No, no testing is 100%. But you're trying to identify an illness with COVID-19 that doesn't present like other illnesses. It's not like the flu. Normally with influenza, you have symptoms before you're really shedding a lot of virus. You start with a cough, cold, and you start to get body aches. And oftentimes it comes on pretty intensely, right? You guys, who's had the flu?
Dr. James,
Can you hear me? Again.
The people that are on the Zoom can't hear you unless you stay close to that microphone.
Can you hear me now?
We can hear you if you stay close to the microphone, but otherwise, if you walk away, we can't hear you anymore.
Okay, there is no microphone, it's just the computer.
Well, if he's staying,
All right.
if he's close to the podium.
I will wander around the podium and say where you can kind of see me too. How's that? Maybe I just carry the computer around. So what was I talking about? COVID and masks and how do you know when you should wear a mask? So traditionally, infectious diseases and viruses in particular typically get into your system, oftentimes through respiratory and inhalation, right? Somebody coughs near you and they're sick enough that they're spreading the virus and they've got some symptoms. Maybe they're not quite sick enough yet to be in bed, but they come to work because they need the paycheck, right? And they bring the illness with them. And they cough, and it's wintertime outside, and so we're all bundled up and we're closer together and we share influenza. The difference is typically you're sick. Even SARS, everybody remember SARS, the SARS virus, right? A more deadly virus actually than this coronavirus, a sister virus. SARS was typically causing people to be sick for about 7 days before they were really shedding a lot of the virus. So even though it had a high mortality, it was a very dangerous virus, we knew who was sick with it. So you come to me in the ER and you're coughing, and I think, boy, you sound like maybe you might have pneumonia. I do an x-ray, it looks like a viral pneumonia. I go, oh, it's probably viral. Oh, I swab you for the flu. Oh, it's not the flu. Ooh, boy, it could be SARS. Boy, good thing I wore my respirator, right? And was careful. Usually not. Usually you're afterwards realizing there may be some exposure. You identify that patient, you isolate them. Their viral load is still climbing, right? They're becoming more infectious. And by the time they're really infectious, 2 or 3 days later, you have them in their own room. Everybody's gowning to take care of them, and they're isolated, nice and safe. Not so with this coronavirus. Part of why we think this virus is not following the normal instruction book on how to present yourself as an infection is that this is a beta coronavirus that has probably been in bats for thousands of years. And that's all fine as long as the bats stay in their caves and we humans stay in our little part of the world, but that's not happening, right? Increasingly, we are building in areas that were traditionally in the wild, and unfortunately, in China especially, there are wet markets where folks will sell wild animals that are considered delicacies, such as bats. Don't get it? I don't quite understand. They sell scorpions there too. I mean, fried. I was in Xi'an, which is the Emerald City, where they have the terracotta warriors, okay, in China. They actually think that fried roaches are a delicacy. Oh, they're so crunchy, is what somebody said to me. Right. Right. And so it looks like, the best we know, this virus jumped through an intermediary host, another animal host, to humans. And that's how it got among us. But it doesn't follow the same instruction set. It doesn't cause symptoms. And so I could be right now a super spreader, and you wouldn't know it. I wouldn't know. I might think that I was fine because I feel fine, but I'm a healthy fellow without a lot of comorbidities, not real susceptible to become very ill with any viral illness, influenza, or this COVID virus. And that's the danger. Almost half of the cases, we think, through the US have been spread by super spreaders. The number is somewhere around 44%, we think. We think what's happening oftentimes is a relatively healthy person, maybe in their 30s, has the virus, travels to an event, okay, carrying the virus, spreading it on the plane, spreading it through the airport, spreading it among their friends, spreading it at the wedding, right? And then spreading it on the way back home. And you can end up with thousands of cases from one person who's got a little, excuse me, a little cough, right? Right, but is, right, you're a little nervous now, right? I'm waiting for you to go. Right. So that's the challenge. I was telling somebody yesterday who tested positive. We test every day at the clinic. And we, of course, counsel our patients as we test them and their positives, trying to remind them, you may feel fine, but you may be spreading the virus. And so you have to change your behaviors. You flight back home to New York, you need to cancel it. You need to stay put, okay? Have food brought in, drop off at your doorstep, right? And change how you behave until you have recovered and are no longer spreading this virus. Thankfully, on the island, as you all probably know, I've been there now 3 years. We've not had quite as much virus as there has been throughout Florida, but there's a lot of viral spread going on because we all still are used to that same pattern of, oh, okay, if they're sick, stay away. But it doesn't work with this virus. You have to assume everybody has it. And so that's why I always wear my mask, because I know I don't want to be on the backside, as I have seen so many of my patients, okay, on the backside, finding out someone was positive. We have had people come into the clinic that later tested positive, and we've all gone, thank goodness we put on our masks, our face shield, our gloves, our full gowns, and we're really uncomfortable, but took all those measures just in case. Because you can bet over this past year, we've had some of those people turn positive. And then we're able to say, thank goodness we didn't get it and get knocked out as healthcare providers. One of the sad side effects of this illness has been, I don't know about you guys, but I've had family members that were alone with COVID in the hospital. I had a 90-year-old uncle who died alone in the hospital because the family couldn't come to be with him. It's a real quandary. How do we manage that? The sadness, emotional sadness of having someone possibly die alone without family there, but yet realizing that one grandchild could come in and expose other people who might die, other patients, and of course the staff that are taking care of the people. It's been a real challenging year. Let me shift gears a little bit. Let's talk about the clinic. A real challenge because it's not so much our patients that we've worried about, but our volunteers. We have a lot of volunteers over 65. Like most of them are over 65, right? And so as we try to figure out, how do we take care of the patients that are high risk, frankly, right? A lot of these folks are working poor, okay? They're serving people from out of town, right? They're working at a restaurant, they're cleaning their houses. There's a high exposure rate there. There's a high risk rate there that they could catch the virus, and there's a high risk they could catch the virus and not know it. There's also a challenge with how our economy works. People aren't incentivized to stay home when they're sick, right? And I can tell you as a physician, I was always told, listen, if you're sick, go outside, vomit in the trash can and get back in and see the next patient. You know, suck it up, man up. You know, you're supposed to be above this, right? It's kind of this mentality, you know, you're supposed to be 10 feet tall and bulletproof and, you know, in 80 hours, your normal work week. It's not so healthy, we're starting to realize in a lot of different ways, but especially with COVID. As a society, we need to start thinking about how do we enable and support our workers to take some time off safely, right, to not be spreading the virus, and also for their own well-being, right? How do we help them recover quicker and more safely? We have some real challenges. How do we get used to wearing these things and know when to wear them and when not to? I would encourage you to wear it whenever possible, because you don't get a chance to go back and say, you know, I had it in my pocket and I sat there and I talked to that guy for 20 minutes. And man, you know, we were kind of face to face because it was loud in the room. So we're sitting close to each other. We're probably 3 feet away. And then I just found out 3 days later that he tested positive. And I had my mask in my pocket the whole time. You know, what are the barriers? You can't hear me so well now, right? And a lot of my patients,
What was that again?
yeah, right? And a lot of my patients, they don't hear so well. So there's a lot of barriers. It's uncomfortable. It's hot. But I'll remind you again, you don't get a second chance. So wear it whenever you can. So let's talk about the clinic. As the virus began to penetrate the area, the smart people were telling us that eventually in the United States, it's going to filter out to the poorer people. They're going to be the ones most at risk, and most at risk to not get the help they need, which is already occurring with diabetes, high blood pressure, which is part of the reason why a clinic exists, right? How do we try to help those folks, but not kill the people that are volunteering, right, to try to help us? You guys have probably looked at and seen some of the curves that show how dangerous this virus is, and it's the elderly, right? It's the elderly. Get above 65, your chance of death starts climbing. Get above 75, it's even higher. When you get to about 80 years of age, death rates actually approach about 80%. Really high. The uncle that I lost was 90, had COPD. The virus killed him. And some people might argue, well, was it really the virus, or was it, you know, his emphysema, his COPD, and his other problems? All of it, right? It's just like influenza. Influenza kills a lot of our elderly because they have other issues already, and it shoves them off the cliff. Would some of these people that died with COVID have lived another 5 or 10 years? Probably not. A lot of them, you know, were frail, but it's caused untimely death. I think that's important to try to avoid that, right? To give them more quality life a little longer. And I'm willing to wear a mask to protect others and reduce the risk that I could be spreading the virus. What about cleaning surfaces? There's been a lot of discussion about, gee, is that a big transmitter? Is it mostly by fomites? It is mostly by fomites. There's about a 1 in 10,000 chance of getting COVID from a door handle, okay, that you then touch. And then you kind of have to rub your eye or pick your nose, or which is, you know, you can see how kids do that, right? We're supposed to be a little better than that. But I don't know. I tend to get pensive at times and put my hand on my face. Yes, Carol, where was your hand just now, right? She caught herself. Her hand was out.
Yeah.
Right? So there's some risk there, but that risk overall is probably pretty low. I encourage people, wipe down surfaces, right? It's better to be safe, right? And take every step you possibly can. We had this idea as we realized we needed to really shut the clinic down because just like at the Boca Clinic, the doors are open, people are going to come in sick and not know it. Some of them are going to know they maybe have something and they're going to say it's just a cold, but they really want to get help. And so they don't really think through that they may be putting people at risk. They just want to come in because I got that cough again, you know, I get every November and I'm still smoking and it feels kind of like I have that bronchitis. So I just wanted to come to the free clinic and get an antibiotic as they come in and spread COVID. They don't mean anything malicious by it. They're just not thinking through it all. So we have to be cautious on the front side. So we basically shut down and said, how are we going to figure out who's safe and how are we going to be able to deliver care? And we said, Oh, we'll just do telehealth, right? Easy enough, right? So we'll have them call and make an appointment. We'll call and interview them. Mrs. Jones, how are you doing? Are you still taking your blood pressure medicine? How are you feeling? And then we'll do a little telehealth visit with them. That didn't work out so well because we found those folks weren't always available by phone. They didn't always answer their phone. They didn't always call us back. Telehealth can be kind of difficult with someone who lives on the boat, for example, I learned. And they're kind of, well, you walk to a different part of the boat to try to get better coverage. The boat? Yeah, I live on a boat. The patient's kind of saying, okay, I usually do pretty good over here on the bow. Okay.
Don't jump.
Right. It got kind of interesting. We also found that when we said, well, we'll just sort through some of these folks, and some of those folks we're going to bring in and have them meet us there and have a provider and a nurse, small crew, keep it safe, gown up, right? Have them wear a mask. We'll wear a gown, a mask, a shield, be safe, right? We had about 50% show up. But then again, right, some of these folks don't have a car or they have a shared vehicle with a family. So transportation schedules, the bottom line is we've realized we need to start back up in person, which is what we're doing. We need to start back the way it worked, the way we know it works. Folks to come and sign up. There'll be some risk there, but we think that we've got a process that's going to minimize those risks, but give them the care they need. Because as you guys probably have all read, throughout the country, folks have put off medical care, right? They put it off because of COVID, and folks that were putting it off have put it off even further, which is a real danger, right? We know that cancers, for example, cancer is the number 2 killer. Who knows where COVID is for this past year, 2020, among death rates? What's the number 3? What's number 2? Twice as many deaths caused by cancer, right? And then what's number 1? Heart. Yeah. And we start looking at those numbers, they're way higher than COVID. Even just moving to cancer is almost twice as much. And so you think, well, yeah, we had to be worried about COVID, right? But it's untreated high blood pressure, people that are smoking, not treating their blood pressure. And then even worse now, because they're afraid of COVID, which is just a paltry number 3. Be sure that the staff are safe and get them in and gear back up. What were our numbers for the year before? Do you remember how many people we saw care delivered off the top of your head?
600 plus.
Yeah. And then, of course, now all of a sudden a big halt. So we're going to get up and running again. And let me say thank you to the Rotarians, because really, as many of you know, when we first started this project, it was really Rotary clubs that stepped up to help us get up and running. And what do you need? Who do you know? You need signs, we got signs. You need lights, we got lights. So it's been an incredible project to be part of, to deliver care to these folks that are in need. What are the clinic questions you should address?
Just to let everybody know, we're opening back up this coming Monday, April the 12th. Monday and Thursday nights at 5 o'clock, strictly walk-in. It's going to be sort of a soft opening. We're not going to publicize it big time because we want to make sure we have all the safety measures that we need in place and that they're working. But if you know of anyone that needs care, just please let them know. We will be available Mondays and Thursdays.
How are you guys handling now that vaccines are coming out? Will you guys be distributing those to people who don't?
Too difficult, but we're going to make sure that we can tell them about places or contacts where they can go and get vaccinations.
They really are opening up much, much more than they were just a few weeks ago. So
Starting
we will provide them with all the resources so they'll know where to go.
this past Monday down to age 18.
Right. And do you have any personal opinion on the 3 that are out there? I know it kind of.
I like so a vaccine is better than none. Even the bad ones are still better than our annual flu vaccine. So look at flu vaccines and efficacy. In the past, we used to say that if you could get a 50% efficacy of a quadrivalent influenza shot, that was successful. Now, what does that mean? Well, the World Health Organization sits down every year and looks at which flus in the Southern Hemisphere, in Australia and other countries, we think are going to be the bad behaviors in this flu season. And they pick those 4 and make a vaccine with those 4. Good years, we may hit 75 to 80% protection. Sometimes it's partial protection. To have vaccines with the 95% protection rates you hear is truly incredible. Now, some people say, well, yeah, but you know what? Those are only allowed under the emergency use authorization. Right? And they basically said, you know, hey, we'll take those from the drug companies, but we're not going to hold them accountable. Don't let that dissuade you from it being a good vaccine. mRNA vaccines have been under development for 10 years. And that coincides with 9 years of research on SARS. So thankfully, there were some really smart researchers out there that had ideas on development, but didn't necessarily have the funding. And suddenly, of course, right, the wallets opened up and government said, what do you need? You know, Britain said, we'll buy 4 for every one of our population. I said, we'll buy 3 for everyone in our population, right? So all of a sudden, these folks that had these ideas, their research was pushed forward probably 4 or 5 years. Are these vaccinations going to be perfect? Well, no, of course not. Are they likely to cause unintended consequences? Pretty unlikely. Some people say, well, gee, you know, how do we know that these vaccines, this mRNA vaccine, isn't going to alter your DNA, right? And you're going to have monkey DNA. No, that's not going to happen. If you understand your eukaryotic cell structure and genetics, you understand how this mRNA works. Does everybody understand the mRNA? You need to talk about it or no? Not interested. Okay, so the Johnson & Johnson is the more traditional vaccine. Okay, it uses a vector called an adenovirus, which is a common cold virus. And this adenovirus has been inactivated, so it's not able to reproduce itself. So it's a minor cold virus. When you look at common colds, did you know that every year about 20% of the common cold is caused by 4 coronaviruses? Yeah, not beta corona like the COVID-19, but 4 coronaviruses. And it's usually pretty mild. It's been postulated that possibly why children don't seem to be as affected and typically don't get real sick with COVID-19. There may be a little cross immunity there, right? There are common colds that they get when they're snotting all over everything, 2 years old, right? 3 years old. May actually be protecting them a little bit. So this vaccine said the Johnson & Johnson made was more traditional. It took an adenovirus, okay, used the plasmid, so it replaced a chunk of DNA, actually RNA, with an instruction set to make a protein that's actually not from that virus, but actually from COVID-19. So it uses the adenovirus to go into your cell, drop off this instruction set to make a protein that your body then sees floating around the bloodstream after it comes out of the cell and says, that's not one of ours. Let's make some antibodies against it and destroy it. Problems with that are you're using a vector and you also have to grow that adenovirus. Usually they use eggs. So there could be some chicken protein in that and the time it takes, right, to allow the virus to develop. mRNA vaccinations, in theory, have looked great for a long time, right? But the question was, how are you going to get the cell to read it? How are you going to be able to reproduce it, make copies of it accurately, repetitively on a large scale, and get it into the cells and get the cells to use it? And they've solved those problems. They've been working on it a long time. And basically what the Pfizer and the Moderna vaccines are an instruction set that when you get the shot, your body absorbs that mRNA instruction set into the cell, reads that instruction set and says, okay, mix this, this, and this, and this, make this protein. Okay, done. Made that protein. Protein goes off through your bloodstream. Your body sees that protein and says, that's not one of ours. We're going to make antibodies against it and destroy that foreign protein, right? And then you get a month later, a second shot. And this time, when your body starts to make the protein, about 12 to 14 hours later, as your body's making more and more protein floating around your bloodstream, your body says, we know that guy. He's a bad guy. He's not one of ours. He's a foreign protein. Hey, guys, the antibody we made before, let's get him, right? And they pile on. You have this robust immune response, which is why you're hearing, especially people under 65, having chills and body aches, right? A little bit of headache, maybe some nausea for a period of almost 24 hours sometimes after their second shot. It's because their body's immune system is robust and had a great response and is achieving 95% protection against death from this virus. What about people that had coronavirus? Do they need a vaccine?
What about people?
Yes.
Who didn't have any reaction?
Yeah, what do you think? What's going on there? What's the problem? Birthdays. Birthdays are the problem. The older you are, the less robust your immune system. Why do we use high-dose vaccines above 65? We've learned over time that people above 65 don't have as good a immune response, don't make as many antibodies against influenza. So we have to give them a high dose. We have to really stimulate their immune system to have a better response. People over 65 that are getting the 2-shot vaccine or even the 1-shot vaccine are less likely to have much as far as a reaction goes to it. And that doesn't mean they're not making any antibodies. They're just probably making less antibodies than the younger people. People that are 40 years old, some of them the day after they get their booster are in bed feeling lousy. Now that scares some people because they think, oh, it made me sick. It gave me the illness. Or I had COVID and I got the vaccine and I felt just like I had it again. Well, yeah, because kind of what's going on is your body is mounting an immune response. All hands on deck. Let's wipe out and attach to and destroy these proteins. That's a good thing. And what does that mean for those over 65 now? We don't know yet, right? It's evolving. It's probably going to mean at some point, folks over 65 may need a booster, right? And we still don't know when will that be. We know that if you had COVID-19 and you get a vaccination, your antibodies go up 1,000-fold. And we've learned that people that had COVID still should get the vaccine because the vaccine gives you protection also against the variants. Not 100%, decreased efficacy, probably down around 12, 13, 50% reduction in efficacy. You start at 95%? Wow. When I first saw the data, I said, baloney, show me, right? So I started digging through the reports of 30,000 patients to see, is this real 95%? I'm thinking, yeah, that drug company's kind of twisting the data, right? Because kind of make the data look a little better or a little worse. The data is accurate. The data is accurate. Real world efficacy is actually probably close to 92, 93%. But still, my background is in microbiology. I'm amazed that we're making vaccines that approach 80 or 90% efficacy. Now people say, yeah, but those variants, right? Those variants. A drop to 85% efficacy or 82% is still pretty good efficacy, right? If we can all wear our masks and be a little more careful to drive down the spread, we'll have less variants, right? When you look at the 3 peaks that have occurred so far in COVID deaths, only one of them has coincided with flu season. The other 2 have been because of stupid human behavior, right? And so we have to not listen to any politicians on either side. We need to listen to our experts for guidance. And yes, things do change. Initially, we said, I think masks might be bad because you're always doing this. So maybe you're touching your hands even more, and that might not be good, right? But we got further along and realized, no, it is good because then you're not launching it across the room, right? But it's changing human behavior, which is one of the hardest things to do, right? Changing human behavior. All right.
Question.
Yes.
The idea of 2 masks.
It helps. 2 masks help. So think of it as if you were trying to filter out room air. right? If you had a second filter, you would trap even more particulate matter. And I can tell you that some healthcare professionals that are, like, for example, I have a roommate who was in med school. He was a critical care doc. He oftentimes will wear a smaller mask over his N95, especially if he's going in to take care of someone who's critically ill with COVID, with he thinks possibly high viral load. He'll wear the second mask, right, and then take it off when he's done with that patient. The idea being that it's getting more of that virus on the surface, right, and trapping a first pass effect. Now, those little blue masks you see a lot of people wearing that have the pleats like Beth has, how long do you think those were designed to be worn in the how long? Yeah, about 20 minutes. Right. So when I put one of those on because I'm doing a central line or somebody's hard to stop and I'm cracking the chest, crazy. I don't wear that the rest of the day, because there's going to be blood particles maybe that I can't see that might be on it. There's bacteria that's on it I can't see. Those are made to be thrown away. So you can wear an N95, but for most of us, that's not really what we need. The N95s, has anybody worn an N95? Miserable, right? You feel like Darth Vader, right? And you take it off and right, it's like, it's dense in your face. Oh, I hate it. I will wear an N95 if I'm in the room with someone who I think is a high risk, but mostly I don't. Mostly I wear shield, just a regular mask. Other questions?
I do. Dr. James?
So will we have annual COVID shots? I think we probably will. The challenge is going to be who needs it. If there's enough, if we can slow down this virus and people start doing the things they should, we won't see as many variants develop. Primarily, the current variants are notable because they have an increased binding capacity to the ACE receptor and a respiratory or GI tract. About 75% better at binding. So less virus, right? You don't need as much virus now to catch COVID. And for the most part, the B series probably has a little higher mortality, but mostly it's more transmissible. But we can drive down how many variants and mutations. We quit spreading the virus so much. But every time someone gets the virus and gets really sick and they make billions of viral particles, yes, the chance of mutation goes up. So we got to stamp down the spread of this to tamp down the mutations. Going forward, we'll probably at some point be looking at boosters for two reasons. Number one, waxing immunity, and also for better coverage of the variants. And already several companies are working on vaccine boosters, right, that cover the variant protein codes, or proteins off the variant viral codes. Other questions?
Anybody else? Anybody online?
Carol?
I was told that the flu vaccines were really helping with COVID as well, COVID transmission as well. And that's why the flu season apparently has not been anything like it's been in the past. Is there some correlation between the two?
So there was a 300% drop in flu deaths this past year. And also Southern Hemisphere had a really low flu year. Why? Is it the flu vaccines? Yes, that's part of it. We've had good vaccine matches. We've had better acceptance, more people getting the flu vaccines, right? I mean, when you see somebody you know or somebody you know dies from COVID, it kind of reminds you that, flu isn't as bad, but both these viruses can kill you, especially if you were older. I'm seeing as a physician more of my patients agreeing with my recommendation when I say, did you get your flu shot? I recommend you get it. And most of them now are saying, oh yeah, I got it. When can I get the COVID? So yes, I'm hoping that overall the vaccination rates will continue to stay high. And part of it also is people are being more careful, and that's driving down flu. And where do we go from here? Well, there will be another pandemic, and from another virus. It'll probably be a flu variant, avian flu, or a pig-based. What do you call them? It's not bovine, but a pig-based flu, right? Swine flu variant. But it could also be another atypical virus that comes out of the wilds. When will this pandemic be over? That's a good question. And it depends a lot on human behavior. We know that the Spanish flu lasted 40 years. Does everybody know that, right? A lot of people don't realize, oh, 1918 flu, you know, and they think, kind of, well, it lasted a year or two. No, it lasted for 40 years. And it wasn't until another seasonal flu came along and displaced them. So we tend to have, as a human race, seasonal illnesses, seasonal viral illnesses that spread more when we're in close contact in the winter months. And so I would expect that we're going to continue to have some virus that's going to be circulating that we'll probably need immunizations for. And at some point, we're all a little more careful in how we behave, right? And we get the vaccinations out to the 4 countries and get them vaccinated against COVID. We'll see this become a more endemic illness, not a pandemic. Death rates dropping further, and it become an illness that we manage with vaccinations every year until the next bad bug comes along.
Well, with that,
I have a question.
so in appreciation for your presentation today, as you know, Rotary is involved in the Polio Plus mission to eradicate polio. So we are making a donation in your name to Polio Plus to continue to do those drops, to provide that service for those people in those countries. So we have 2 countries left. I believe that's all that's left.
Awesome.
Yes. So we're getting closer.
Getting closer, right?
And hopefully, as you know, so we've talked about this a little bit, that the methods that Rotary International has used to get this out into the corners of the world may be used for the COVID virus vaccinations and that type of thing as well. I mean, I haven't gotten there yet, but you know, the protocol may kind of follow something similar.
We're learning a lot. We're learning a lot, and hopefully there'll be things learned about not just vaccine development, but also things learned about the logistics of distributing vaccines to other parts of the world. And that's one of the challenges, you know. I talk to people about, listen, thank God you're in a wealthy country and you have a car and you can get a booster, right?
Yep.
Because in a lot of parts of the world, to get them even one shot, even if it's only 50 or 60% efficacious, is going to be challenging. And it's going to take all the countries working together. And I watch the news and I think, boy, you know, we got a long ways to go.
Yeah.
But, right, there's enough of us that are making that effort and supporting it financially and also with our good deeds, and pushing our senators and our own government to get behind it. It'll happen.
Yeah.
It'll happen. We just got to keep pushing.
Absolutely.
I saw a question online, young lady in the top left.
Kathy, Janet.
I did have a question, but
Oh, no, we can't hear you, Janet.
okay,
You know
It's
why? Because the TV's out.
it's okay.
I'm just hoping to put it in the chat box.
All good.
Like she's waving us off.
You want to put your question in the chat box, Janet?
All good since we're done. Oops.
All good. All right. Thank you. Appreciate that. I think that was very informational. So we're kind of coming to the end. I know we got a little bit of a late start today. Again, today was a little bit crazy. But so we'll go ahead. If anybody has any happy dollars, I know everybody's still enjoying their lunch or still just getting their lunch.
I just want to thank everybody that was part of the food rescue and everything, so I appreciate that very much. And everybody did that, and then here's the color that I was on a couple weeks ago. I was
I
online.
didn't keep track of that really, but thank you. Appreciate that.
I was online.
Anybody else have any happy or sad dollars? Anything they want to roll?
We're all the people who volunteered for the art festival. The art show. No, I already got your blood.
Awesome. And I'm gonna put in 5 today, 1 for the Arts Festival, again, just to thank everybody. 3 for the birthdays that we had some, yeah, I'll get it. We did a 3 birthday celebration this last weekend. It was a lot of fun. It's almost too much fun. But we had a wonderful time. And, you know, the rest is just to thank everybody for chipping in and doing their parts. And we've not done major things this year, but we've done little pieces here and there that have still made an impact in our community. So that's my vibes. Esther.
Well, I do want to commend Carol Peterson and our yard. They both work very hard behind the scenes. And I know a lot of other people that too. I can have view what they really
Absolutely.
do. It's a real scramble. So you're agreeing.
Absolutely.
Of course, we're always happy to see you here.
Absolutely.
I have dollars and quarters.
That's okay. Thank you.
But
Appreciate that.
Always nice to come to Rotary, even though it's not like it was. I'm always excited when I get to come to Rotary.
Well, we appreciate that.
Excited to see you.
It's ready to get back to my.
Oh, I know.
Yeah.
It takes time.
I had $1 in for getting all those.
Okay, well, thank you, Mr. Ward, and have a great
We
day.
changed it. It was the boat races. So Patrick's version is mini golf.
Mini golf, and I went 2 hands at all these dollars.
So you have lots to get rid of.
Yeah, sure, that's what Jen said. Where did you get those dollars? They're not very good.
Exactly. All right, anybody else? All right, Brad has some license plate covers. If anybody wants any, he found them in the storage.
Yep.
Um,
It used to be in our garage.
Yeah, and so I thought it would be nice just to get those out to people who want them. And on a caveat to that, those of you that don't know, are in the process, Rotary is, they're coming out with a license plate. They do have to do a certain number of pre-orders in order to get that cleared, so they're doing that now. I think there's a link that, I think Tracy put it on social media, on the district social media. But if you're interested in that, it's out there, so you can find it. Anything else from anybody? We got 50-50 today, Ed? $5. $5. All right, who did not buy a ticket? Janet, did you buy? Or Jennifer? Got $5.
Last year, 746.
You got more dollars.
I got more dollars. I got my dollars back.
There you go. Thank you.
Yeah.
Okay, we'll go ahead and close this up, but everybody who's still eating, please stay and enjoy your lunch. If you want to get a to-go box, I'll have her bring to-go boxes in. I know everybody's on a time schedule. But whatever way you want to do is fine with me. And we'll go ahead and close out. Esther, would you like to lead us out? Is it the truth?
Number 2
Is fair to all concerned?
Number 3
Will it build goodwill and better friendships?
Number 4
Will be beneficial to all concerned. Thank you very much, everybody. Have a great afternoon. Thank you. Bye, everybody.